Yeah. All right. Welcome, everyone. And it's my honor today to be able to introduce Dr. Syed Ali as our grand round speaker. So Dr. Ali is one of our current fourth-year orthopedic surgery residents. He's originally from Massachusetts. He attended Washington and Lee for undergrad and then was a medical student at UMass. During his time at UMass, he did a Doris Duke fellowship and worked with the IGOT team for a year. So he first came out to UCSF at that point and then spent time in Tanzania. And I think that was a great experience for him as well as for the IGOT group here, getting to have him as part of the team. He was able to develop skills in international work and really push forward projects and kind of demonstrate his goals and potential as an orthopedic surgeon at that point. We were then fortunate to have him match with us as the six-year research resident. And since coming to UCSF, Syed's done a great job as a resident. He's been thoughtful, he's hardworking, he's continued with his clear interest and passion of international work. He's spent his year of research, which we'll hear a lot more about today, but doing more international work. He was funded by NIH T32 grant. His work has been recognized with multiple awards and really across the board has been just outstanding. He has a strong publication record and really has done some impressive work. And I think the IGOT people especially are very appreciative and thankful for all of his contributions. And after completing residency, Syed will do a arthroplasty fellowship. So he's currently applying for that, and we look forward to his bright future in that direction. So Dr. Ali, thank you for presenting today, and look forward to your talk.
Thanks, Dr. Lansdowne, for that very warm welcome. So my talk today is on advancing the evidence in global orthopedics and lessons learned from the Tibia trial. I have no disclosures. Me and other people involved in the trial have received funding from many sources. Me personally from the Doris Duke Foundation and the NIH, and there's others listed here. So to start, I just wanted to list a few take-home points. And to summarize, local antibiotics have emerged recently as a promising strategy to reduce orthopedic infection. But most research has been conducted in high-income countries and may not be generalizable to low and middle-income countries where the burden of disease is the highest. Today, we'll go over the current evidence on local antibiotics, why conducting this work in a low-resource setting is both ethically necessary and scientifically valuable, and where the gaps in research lie. And we'll specifically talk about the gentamicin open tibia trial, or Tibia, which I was very fortunate to be able to participate in and contribute to. I do apologize, I'm losing my voice a little bit. Thankfully, Michael Flores is in the crowd, so if at any point I falter, he will step in. So I just wanted to start with an anecdote from Atul Gawande, who many of you may know. He's a Brigham-trained general surgeon who is of Indian descent. And he recounts traveling to a hospital in his ancestral village in India, where he expected, as an American-trained surgeon, that he could have a thing or two that he could teach the local surgeons. Instead, he ended up learning just as much from them as they learned from him. And he was very impressed with their ability to innovate and overcome problems. He found that doing so required a readiness to recognize problems and a determination to remedy them. And I thought that was a very valuable piece of insight. So as we all know, and we've seen before, more than 3/4 of the global population lives in a lower middle income country. This population has a very high rates of orthopedic trauma injury, up to 5 times higher than their counterparts in high-income countries like the US. This is predominantly due to road traffic injuries. Road traffic trauma is predicted to be the 8th leading cause of death and 4th leading cause of disability by 2030. Approximately 50 million people a year suffer non-fatal injuries each year from road traffic trauma, with many incurring disabilities. Africa is particularly susceptible. Africa's road trauma burden is already the highest in the world, and is projected to increase by 80% over the next 20 years. On this continent where HIV, TB, and malaria draw most of the headlines and research dollars, trauma actually accounts for more death among children 5 to 14 than all three infectious diseases combined. And when road traffic trauma is non-fatal, orthopedic injuries, especially open fractures, are common. Open tibia fractures, in particular, are among the most common, most severe, and most devastating of orthopedic injuries worldwide. The standard of care for open tibia fractures, as we all know, remains immediate systemic antibiotics, prompt surgical debridement, and surgical stabilization. Despite these interventions, infection remains a major problem. This is true even in high-income countries, strictly following the standard of care and equipped with the most modern surgical techniques. Castillo et al. Reported an 18% rate of infection in a 10-year period in a systematic review of 34 studies in 14 countries. Similarly, Syed et al. Reported a roughly 18% rate of infection in their more recent systematic review in 2021. As we know, infection is a major problem. It significantly increases the risk of delayed healing, non-union, disability. In severe cases, it may even require an amputation. Syed et al. Reported a 15% rate of non-union and 7% rate of amputation following open tibia fractures in high-income countries. These are obviously associated with high economic costs, not only direct hospitalization costs, but also the indirect costs of loss of work and economic output. In fact, 22% of patients did not return to work at 1 year. So it's clear that additional strategies beyond the current standard of care are needed to combat and ideally prevent infection. Local antibiotics are one proposed solution. There is a long-standing historical precedent. Locally applied antiseptics date back to the 1800s, when Joseph Lister began using carbolic acid as an antiseptic. In 1939, Jensen and colleagues were able to reduce their infection rate for open fractures from 30 to 5% by using sulfanilamide powder directly into wounds. Several similar studies followed. And in the modern era, European surgeons began using PMMA impregnated with antibiotics to treat infected joint prostheses as early as the 1970s. Locally applied antibiotics offer several theoretical benefits. In particular, increased local delivery to the tissue of need without significant risk of systemic toxicity. High concentrations of antibiotics have also been shown to be effective against biofilm. So local antibiotics may be particularly effective against biofilm-producing bacteria, as is commonly seen in orthopedic infection. And they might be especially useful in situations where local delivery of systemic antibiotics is limited, such as with open fractures, where soft tissue injury and periosteal stripping limit the local blood supply. Local antibiotics are widely used in many areas of orthopedic surgery today. In the spine literature, vancomycin powder or pixie dust is frequently used intraoperatively, and there is a body of literature regarding its use. A recent meta-analysis of 21 studies by Bakshishian et al. Showed that topical vanco powder decreased the odds of developing a deep infection. However, this was predominantly low level of evidence studies and only included one small randomized trial, which did not show a significant difference. More recently, a 2021 review article looked at vancomycin for instrumented spinal procedures. And again, the highest quality studies did not show a significant difference. However, these studies may be limited by heterogeneity in study design, population, and type of procedure. And it's clear there's a need for higher quality prospective studies. There's additional examples in the sports literature where Barron et al. Conducted a retrospective review of cases in which an ACL graft was or was not treated with intraoperative vancomycin. They found that vancomycin-soaked grafts did decrease infection risk tenfold. However, again, this is a level 3 retrospective study. In arthroplasty, antibiotic-loaded cement is routinely used both in primary and revision procedures. Intra-wound vancomycin has also been used in primary and revision settings. A systematic review in 2022 by Mosagavi et al. Showed lower rates of PJI in primary and revision patients. However, they note that all included studies were low quality evidence, and the authors advocated for higher quality studies, ideally a randomized trial. This desired randomized trial was finally conducted and published this past year by Mulper et al. At a single center in India. They enrolled 1,022 patients. They were assigned to intrawound vancomycin versus no intervention. Their overall rate of infection was 0.66%, and they found no significant difference in the rate of PJI between local and non-local antibiotics. In fact, the vancomycin cohort actually had a higher rate of minor wound complications. So the highest quality evidence suggests local antibiotics are generally well tolerated, but when the starting rate of infection is so low, less than 1%, they may not be necessary. Local antibiotics have also been studied in trauma. And there's both, one of the strengths and challenges in this population is the diversity of techniques. So local antibiotics may be delivered by a carrier or on their own as a powder or aqueous solution. Some carriers, like PMMA beads, allow for sustained antibiotic release and occupy dead space. However, they're non-absorbable and require a second surgery to remove them. This increases their cost and morbidity of use and makes them challenging to use in low-income settings. There are absorbable carriers like calcium sulfate or hydrogels, which eliminate the need for a second surgery to remove them. However, they're very expensive. A single use can actually exceed the annual income of many patients in low-income countries, and thus they're not widely available. Finally, there's aqueous local injections or topical powders. These are the cheapest. They provide a burst release with high immediate concentration. However, there's concern for subtherapeutic concentration over time, which may predispose to antibiotic resistance. Local antibiotics have been studied, including by Yarbrough et al. In a rat model. They actually showed that the high concentration of local antibiotics that was achieved by an injection of gentamicin was actually more effective in lowering wound bacterial counts than a sustained release via calcium sulfate carrier. Many studies since then have yielded conflicting evidence, so that's not exactly conclusive. What about the choice of antibiotics? So as we know, the most common organisms that infect open fractures are gram-positive cocci and gram-negative rods, with gram-positives being about 75% of the microbiology. Local vancomycin is thus frequently chosen given its coverage of gram-positive organisms and MRSA coverage. However, vancomycin is actually relatively expensive and can cost $20 to $44 per single application. There's also concerns about antibiotic stewardship. Aminoglycosides, interestingly, are not thought of as first line for staphylococcal infections. In fact, this ICU microbiome review does not even recommend them. And this is especially true when used systemically. However, interestingly, studies show when they're used locally, one, they're synergistic with systemic cephalosporins, which is often the case in orthopedic surgery. And two, local administration actually achieves a high enough concentration to be bactericidal against gram-positive cocci. And this is concentration dependent. Aminoglycosides are also broader spectrum and cover gram-negative rods. They're relatively inexpensive and can cost 20 cents per application, and they're widely available in both high and low-income countries. So what does the literature say about local antibiotics in the trauma population and for open fractures? There's several low level of evidence studies that support their use. Lawing et al. In 2015 did a retrospective study showing lower rates of infection in patients who had been treated with local aminoglycosides following open fractures. There's also several basic science studies that corroborate this. Hovis et al. In 2018 used a rabbit model showing that local vancomycin decreased the risk of bone infection and biofilm formation. There's only one level 1 study so far, which is the Vanco trial by the Metric Consortium, which we're all probably familiar with. This is a multi-center randomized controlled trial that looked at vancomycin powder in high-risk periarticular tibia fractures, and they were both closed or open. The study enrolled 1,036 patients and found an overall rate of infection of 6% in the treatment group and 9.8% in the control group, which approached but was not statistically significant. When they looked at open fractures, they found a 12.7% rate of infection in the treatment group versus a 19.3% rate in the control group. Their main conclusion came from a subgroup analysis of gram-positive deep infections, which did show a significant reduction, and there was no change in the rate of gram-negative infections. To this end, Metric is actually investigating vancomycin and tobramycin together in the currently ongoing TOBRA trial. So this ultimately brings me to our clinical question, which is, will a low-cost aqueous gentamicin solution injected following wound closure reduce infection following open tibia fractures at a level 1 trauma center in sub-Saharan Africa? And we sought to assess this via masked, placebo-controlled randomized trial. So why do this study and why do it in Tanzania? Well, one, there's a clear ethical responsibility to conduct research where the burden of disease is the highest. And the burden of disease is enormous in low and middle income countries by volume, by rates of infection, and by economic impact. Historically, research has been conducted almost exclusively in high income countries, and these treatment guidelines may not be generalizable to low and middle income countries. This mismatch is part of the well-documented 1090 gap, which only 10% of global medical research is directed towards the health issues that affect 90% of the world population. There is a great need for locally driven studies. At the same time, there are many barriers to doing so, including limited resources, infrastructure, and experience. One potential way to bridge this gap is through academic collaboration. Partnerships between low, middle-income country and non-LMIC researchers can provide the essential support they need in terms of study design, research education, division of labor, even access to funding. And Ibrahim et al. Reviewed these collaborations in 2018 and emphasized how they should prioritize capacity building, mentorship, and bidirectional knowledge exchange. IGOT, as we all know, is a success story on this front and has collaborated multiple times to successfully complete multiple high-quality prospective studies addressing problems in low-income countries. And this has been through the form of academic, research, training, material, and financial support. Importantly, these studies are often driven or originate from a need identified by a local collaborator. So ultimately, the high burden of disease is an opportunity to intervene and make the greatest possible difference. You can imagine that lowering the rate of infection from 40% to 20% has enormous potential in the low-income population, where follow-up can be limited and the economy predominantly relies on young men and women with functional limbs. Additionally, the high volume of cases facilitates study completion and study designs that may not be feasible elsewhere. For example, at Muhimbili in Tanzania, more open tibia fractures were enrolled in a single month in our prior study than in an entire year at some level 1 trauma centers in prior trials in high income settings. So by shifting research to where the burden is greatest, we not only address critical gaps, we can also potentially create win-win scenarios where we advance evidence-based care in low-income settings and also foster innovation and benefit all countries. There are obviously ethical considerations to doing research in low-income settings. One, we should ensure local capacity building and benefit local clinicians and local institutions, not just the external investigators. Two, we should avoid exploitation. Participation should be voluntary, should be informed, and the local participants should have access to the benefits of the research. This means that the intervention study should be affordable and they should be implementable in the local setting after the study is completed. And ideally, we should follow the highest standards of care, not just the local standard of care. So this has been an issue in the past in placebo-controlled trials, where control participants did not receive the same treatments as a control participant would in high-income countries. And ideally, ethics should be universal and not dependent on which country you are in. So this brings us to the GoTibia study and the pilot GoTibia study, which, as Dr. Lansdowne was mentioning, I was very fortunate in medical school to receive a Doris Duke grant to pursue. and spent the better part of a year on the ground in Tanzania, helping with getting these studies off the ground. So the pilot Tibia study was a 100-patient pilot study conducted at Muhimbili Orthopaedic Institute in Dar es Salaam. It enrolled adults with open tibia fractures, specifically Gustula types 1 through 3A. And these patients were randomized to either local gentamicin or saline placebo and had 1-year follow-up. And the idea is local gentamicin a low-cost, feasible, easy to implement intervention that can be performed at the time of the index surgery, and will it reduce the rate of infection? And this is especially important in this setting where there's limited follow-up, where infected patients may not present for months or years until it's too late to save their leg. So the inclusion and exclusion criteria are listed here, but in brief, we included adults with closable open tibia fractures that presented within a reasonable time of injury and did not have confounding injuries. An important part of this is that we wanted to provide the highest standard of care for all participants, including the control participants. So everyone actually got systemic antibiotics and had this paid for by the study. Whereas normally in Tanzania, maybe 50% of patients get systemic antibiotics, the standard of care here in the US, because they have to pay for it and they often cannot afford it. So our study will likely underreport true effect in this setting. So the primary outcome of the pilot study was to assess feasibility. This study has not even been done in high-income countries. Can a randomized mass prospective trial be done effectively in low-income countries? Secondary outcomes are what we wanted to study in the definitive clinical trial, predominantly fracture-related infection and additional findings such as suggestive FRI, non-union, quality of life, and so on. So the study timeline was that patients were enrolled over 1 year and followed up at standard intervals over 1 year in which data was collected. In order to maximize enrollment, patient retention, and data quality, we did pay for 3 full-time local research coordinators, had multiple frequent check-ins, both for data and enrollment. And we chose to alleviate the financial burden for patients in several ways, including, as I said, paying for their systemic antibiotics, paying for their follow-up x-rays, and also by just making sure that they were on track to follow up by frequent phone calls and calling patients who did not follow up. So what ended up happening? We ended up enrolling 100 patients over the course of the year. This was about 13 a month, with 84% following up at 1 year and 95% having complete data at all time points. What were our findings? So as I said, this was a feasibility trial to see if this study is even possible. However, we found no statistically significant difference in terms of baseline characteristics, and no significant differences in any of the secondary outcomes, including FRI, including non-union, reoperation, health-related quality of life, or fracture healing, whether radiographic or functional. However, that was not the goal of the study, as I said. Importantly, there were no significant differences in the rate of systemic side effects from aminoglycosides, such as AKI or ototoxicity, which suggests that local gentamicin is safe to administer and does not lead to systemic side effects. So we concluded from this pilot study that this type of study is feasible. However, it's underpowered for efficacy, which we knew, and that a larger trial will be needed. This brought us to the gentamicin open tibia or Tibia definitive trial, which used the same masked randomized intervention and study protocol with the same inclusion and exclusion criteria, but a much larger enrollment target, aiming to enroll about 890 patients total. In this study, our primary outcome is the rate of fracture-related infection. There are several secondary outcomes, including non-union, reoperation, quality of life, fracture healing, and CRP. And many of these outcomes are adjudicated by an independent committee. In terms of the study, it is an ongoing study. As of February 2025, so this past month, we've enrolled about 300 patients and are on target with the initial projections. We can't compare the trial arms as they remain masked. However, our baseline characteristics are similar to prior studies and show that these injuries are predominantly sustained by young male patients and predominantly due to road traffic trauma. The majority are Gustilo-Anderson 3A. Most are treated with X-Fix, but many are treated with nails. And they're often, but not always, treated within 24 hours of injury. We've shown that so far there's robust follow-up, with 85% having follow-up at 1 year, whether in person or via telephone. Interestingly, this study does show a lower rate of FRI than prior studies show so far, with a 7% rate overall. So this does lead to the question whether our provision of systemic antibiotics is making a difference, because prior studies have shown a rate up to 30 to 40% in the low-income population. Additionally, there have been no significant systemic adverse effects associated with aminoglycosides. The most important question is, does the intervention work? And that is still pending, as that is this is a mass trial, and we have not unmasked our results yet. So stay tuned for the final results. Additionally, there's multiple sub-studies that are embedded within the larger trial, including the study I was working on last year as part of my T32 grant, which is looking at CRP as an early predictor of FRI. So obviously, patients in this population have a low rate of follow-up outside of the trial. Is there a way early on to predict patients who go on to develop infection at 1 year from less virulent organisms? And can we do so using CRP values early on? And the early results have been promising at the 12 and 26-week mark, but obviously more data is being collected. Hopefully will show statistical significance. Additional studies are being done to look at the local microbiome and the economic impact of these injuries and reducing the rate of infection. Potentially in the future, this can be extended to other centers using strategies such as those used in the US, such as cluster randomization. So I think takeaways for me is that, one, there's many challenges to doing research in this setting. And I think the ability to get this pilot trial and the current definitive trial off the ground really speaks to the MOE team and the IGOT team. For me personally, during my year, there were many challenges. Things like not having internet for weeks to months at a time, going through 3 different computers due to various power surges. Even the process of getting a visa was challenging for that length of stay. But ultimately, I think it was worth it. Coming back to our take-home points, so FRI, as we know and have seen, is a global problem, but it disproportionately affects low and middle-income countries. Local antibiotics are promising low-cost intervention that may help reduce FRI. Finally, high-quality prospective studies are feasible and I would say needed in low-resource countries. Just wanted to thank a lot of people. Thank you for letting me present this research, and also the entire MOE team, including Dr. Honga, our MOE coordinators, and all of the MOE residents, and then obviously the IGOT team, who we're all familiar with, including many former IGOT fellows, some of whom are in the audience. Thank you.
Right. Well, thank you, Dr. Ali. That was outstanding. And definitely looking forward to the final results as those become unmasked. I think we have some time for questions, thoughts.
Thank you, Syed, and congratulations on excellent work. And thank you for sharing your work with us today. I think one of the early findings, which might be really, really interesting, is also not unexpected, that giving the systemic antibiotics is going to have a huge effect. What do you think it would take to make systemic antibiotics not paid for by the patient and to offer that as standard of care? And could there be any path forward for that through a global initiative?
Yeah, I mean, that's a great question and a very astute observation. Obviously, as we know, that's the most important thing. Historically, it's less common in that setting just due to cost. And we did look at, how much it would cost to do that universally. The problem is patients predominantly pay for their care. So like every intervention, historically, and when I was initially in Tanzania in med school, like every patient would pay for their own antibiotics. They have to go to the pharmacy, pick it up. So one, it would be delayed, and two, it would be very expensive. And then three, they follow up very late. So, they're presenting, a day after their initial injury. Recently, there actually has been a governmental push to create a national health insurance. So when I went back there for my global rotation this past year, there were actually a number of patients with governmental health insurance. So I think that's actually in the works. I just think it's going to be very expensive, and we'll need, as you were saying, assistance from NGOs and other just other sources of income to make that more universal for patients who are not eligible for that governmental insurance. And right now, it's a small subset. But as you're saying, I think it really is an economic problem right now, and finding sources or lowering costs would be the way forward.
Sorry to monopolize the microphone, but do you know, are there any other health interventions paid for by the government? I don't know, vaccines, mosquito nets. I mean, is there anything that there's already a model that maybe you could do sort of a cost analysis paper to then convince them that just pay for one dose of?
Yeah, I mean, it's a great question. So in terms of governmental programs, it's actually mostly done by NGOs and I guess prior to this recent year, USAID. But there's obviously a role for, the government stepping in. There's been a lot of work done in other, medical specialties, especially ID, OBGYN. More recently, we've been showing that the economic benefit of orthopedics is also there, even though it's not quite as high as ID or OBGYN historically. Now that we've addressed the low-lying fruit in those fields, the economic benefits of orthopedics is actually approaching feasibility. So I do think there's a role in the future, and hopefully we can get the government to buy in, but it will take time and more research to show that.
Thank you.
All right, Dr. Diaz on Zoom said, congratulations, great presentation. In the arthroplasty world, there is evidence for two important factors. First, the bacteria that produce implant-related infections varies geographically. Second, there's a concept called intraosseous regional antibiotics, mainly used with Bank, but also some evidence with cefazolin. Any comments on these concepts to be applied in your experience in Tanzania?
Yeah, I mean, great questions. I think, as Dr. Diaz astutely notes, like there's local variations in microbiome. And that's one of the reasons we're actually doing the wound culture sub-study is patients in these settings have often heavily contaminated road traffic injuries. And you can imagine that, predominance of GNRs or anaerobes is probably higher. So one of the sub-studies is actually taking wound cultures when they present to the ER and seeing what that grows. And actually a component of the Tibia trial is every 3 months showing that gentamicin remains effective on the local microbiome. So there's actually efficacy testing included as part of the trial, which I didn't go over. So I think there's definitely, it's definitely an important thing to note and keep in mind when you're doing a trial is making sure that, the antibiotics we're using are effective. In terms of intraosseous, obviously that's been studied in the arthroplasty world, especially here in the US. I think for us, the main considerations were making something that's feasible and economically, as economically affordable as possible in this setting. So even like just giving vancomycin, for example, is too expensive for this setting for most patients, whereas gentamicin is 20 cents a dose, and it can be injected pretty much anywhere. So I think in the future, though, that would be something definitely worthwhile.
Dr. Sabatini has her hand up on Zoom.
Hi,
Go for it.
Syed. Sorry that I wasn't able to be there in person. The unfortunate realities of having to cover call. Excellent presentation. You have always done excellent work, and it's an honor to have you as part of the UCSF team in so many ways. So thank you. Question about not specifically about antibiotics and broken bones, but in your work, because you've had this longitudinal relationship with the crew in Tanzania, as has Dr. Shearer and Dr. Morshed, I wonder if you could just reflect a little bit on, as you've been doing this amazing work, how have you worked to build research capacity in Tanzania and work to support your local colleagues and really include them in the research and not like do the research on them or for them, but with them? Can you sort of talk a little bit about that and how you've really tried to make sure that not just the ethics for the patients, but the ethics for your local partners, and really trying to make sure that we're enhancing research capacity while there?
Yeah, I mean, that's a great point, Dr. Sabatini. And obviously, as we were saying, it's important to address the local questions, not what we think is important, but what our local collaborators think is important. I think, IGOT has taken a multi-pronged approach to this. And, part of it is one, the SMART course that's held every year has a research component where there's a research day and we kind of go over how to ask the right questions, how to develop a research study and, have a plan to address those questions. And people like Dr. Morshed and Shearer, who are obviously very well versed in research, will go over those ideas and provide constructive criticism and feedback. So I think kind of teaching the process of research and how to think about it is part of that in holding the courses. I think the second part is really having our local collaborators be the ones to drive much of this research. So as I was mentioning, Go Tibia actually came about due to an idea from Dr. Billy Honga, because he had seen that study, the Long et al. Study in JBJS, and thought, well, this might be something we can actually do. Like we can't do vancomycin or, calcium sulfate or hydrogels, but just injecting gentamicin, that's something they can do in Tanzania. And even the prior studies of external fixation versus intramedullary nailing were again driven by and proposed by our local collaborators. So I think being there to fill in the gaps while allowing our local collaborators to fill in the vacuum of what needs to be studied and how to kind of get there is would be my recommendation.
Say a terrific research in such challenging circumstances. You recognize the important role that non-governmental organizations play in developing countries in healthcare. So the Swedish Committee, Red Crescent and Red Cross, there's a lot that goes on there. There's also a lot of governmental funded organizations, and some of these organizations are partially government funded. So with defunding of USAID, do you have any sense of what kind of an impact this is going to have on providing healthcare in this part of the world?
Yeah, I mean, it's a great question. Obviously, a topic that's very recent and hard to predict. I mean, it's going to have an enormous impact, I think. Even like as a lot of this research was funded by the NIH, and right now, as we know, there is an indirect cap on NIH funding, so it'll have a major impact. I think it's hard to predict like exactly what's going to happen, but I do think that we'll see a lot of the really pioneering work being done across all medical specialties be cut back and readjusted. And unfortunately, there will probably be a need to seek alternate funding, potentially from industry. And when you do that, there's questions about bias and, are you really addressing the local needs versus industry needs? So it's a really good point and one we'll have to keep an eye on.
Really well presented and great work. I have just a question from an experimental design standpoint. So the PIGO study that you did was actually quite extensive, 100 patients ballpark, great follow-up, but no difference between groups. So when you initially did the study, how did you do the kind of estimate of sample size or power analysis? And did you redo that after the results of PIGO, or did it not provide any additional information that would contribute to powering the big study? Because you would hope that there'd be some trends towards favorable outcomes and repower the study and figure out the right sample size. So how did you go about the decision to continue with Go after the results of PIGO, and how you decided what the sample size should be?
Yeah, it's a really good question and very astute observation. I think one of the things that we struggled with initially is that some studies have shown very high rates of infection, as I was saying, 30 to 40% in the low income setting for open tibia fractures when you consider the high rates of GA3 injuries. However, that's in patients who often don't get systemic antibiotics. And so the initial power analysis was conducted on a reduction from 40% to say 20%, which obviously I think when we calculated it would require something like 200 patients. However, when considering the ethics of that study, we would not be able to do it because you would be essentially forcing the control group to receive a lower than standard of care in our setting, even though that's the standard of care in their setting. So then we had to consider, well, what will be the power analysis when everyone gets systemic antibiotics? And part of the pilot study was just to see like what is the rate of infection when everyone gets systemic antibiotics. So I think it was kind of an evolving thing. I think initially we weren't really sure how giving everyone systemic antibiotics would change the baseline rate of infection. And when we showed it was about 10%, that's when we were able to do a power analysis for 10% versus 5%, which ultimately yielded the overall numbers. But I think, it wasn't as clean cut for sure as a study where you're saying, okay, it's definitely going to be this baseline rate, and we're definitely going to target this for our power analysis.
Syed, thank you for that. Niels Bohr used to have a horseshoe above his door, and somebody asked him, why do you do that? You're such a consummate scientist. And he said, because they tell me it works, and there isn't much downside. So now that you've taken a deep dive into this area, do you think I should continue to put antibiotic powder in spine wounds?
It's a good question. I mean, I will say the systematic review suggests that for uncomplicated, low-risk instrumented spinal fusions, there is not a significant difference at this time. But again, as I was saying, the level of evidence of those studies is low. And that's why we do need these prospective randomized trials with high levels of evidence, which there really aren't very many that I'm aware of. So I think it's reasonable. I mean, it's definitely, it's one of those things where it's easy to say don't do it, or the infectious disease team will tell us don't do it for these reasons. But if you're the surgeon and you're having to go back and do a revision surgery on this young patient with an infection, then it's hard to change your practice and say no, I'm not going to do it for the purposes of stewardship.
All right, Dr. Shearer has his hand up on Zoom.
Hey everyone, sorry I can't be there in person. Syed, awesome work. Congratulations for all the things you've done. I really appreciate all your contributions to IGOT and this research program. I just wanted to comment first on the methodologic question that Hubert had, and then just ask Syed another question as well. For the methodologic piece, the power analysis was based actually on the prior trial in Tanzania, the X-Fix versus nail trial, and we used the rate of infection with a goal of a 50% reduction. So that gave us the definitive trial power, and so the power sample size for the feasibility study was just based on choosing 10 to 20% of the definitive trial, which is sort of a typical number that people use for doing a pilot trial. One of the interesting things, we had initially planned to potentially revise our definitive trial power analysis based on the results of the pilot trial, but what you noticed was there really wasn't even a signal of a beneficial effect from the gentamicin. But one of the things we learned in the trial was that they were injecting Syed, I think, or I don't know if it came through, but they were actually the original line trial was 80 milligrams of gentamicin and 40 mLs of saline. And that volume of saline, if you think about a 40 cc syringe, it's like a huge volume of saline. And what was happening is a lot of the patients, they were not really getting the dose. Like they would start to inject it, and then maybe after 5 cc's, it would start extravasating from the wound and they would stop. And we recorded that amount that was being injected each time, and the average was only like 5 or 10 cc's. So what we did in the definitive trial was we actually concentrated the 80 milligrams in a much smaller, in a 5 ml concentrate injection, so that they would actually get the full dose of the gentamicin administered locally. So the definitive trial is actually looking at a significantly higher concentration of gentamicin, which we thought might help. So it's really a completely separate trial of a higher concentration intervention. So we didn't make any refining of the power analysis based on those results, but it was very helpful for us to learn that like a 40 ml injection was not going to be feasible. So really, that was the one of the main benefits of doing that pilot trial. The question, and I think it also speaks a little bit to what Dr. Sabatini was getting at. Syed, you did a great job, I think, of talking about how this idea really was driven by our local partners. Like I didn't have the idea of gentamicin. It truly was Billy Honga's idea. But the second piece of it that maybe you could talk about, because you've witnessed it personally, Syed, is just how this trial actually works, like who's actually collecting the data. I mean, you spent almost a year there, but did you spend the time physically, personally collecting the data? So I wonder if you could speak to a little bit of kind of who's actually collecting this data, doing the research, doing the informed consent, and what our role has been as the collaborating partners in that process.
Yeah, it's a really good point. And I guess, as you're saying, also speaks to Dr. Sabatini's point in that our job, or my job, is to train, but not to actually do. So initially, the coordinators, they had experience with REDCap and data collection, but not doing a randomized trial and not randomizing patients and not collecting some of the data we were looking for. So in the beginning, I would help collect the data, or I would do it with the coordinators, but the goal was always to have them be independent and let the local coordinators have the capacity to, make some of those judgments and enter the data themselves without requiring much input from us. So it really is a locally driven and managed trial where we're just providing additional support and training and maybe some, redirection as needed. But to Dr. Shearer's point, it's really the local coordinators and the local team who are, on point in the ground. We're not running the trial. It's definitely Moi's trial.
Dr. Ding.
Sorry, go ahead.
Oh, sorry. Dave, did you have?
Yeah, I was just going to comment. Yeah, I think that's great. I think it's important. The coordinators are all employed locally at the hospital as well. So even if our funding goes away for whatever reason with our current political situation, they're going to be there. They'll continue to have jobs, and they have an amazing expertise now. I mean, the difference between now and when I went there as a resident 15 years ago to start doing this work is it's impressive. They really can do all this stuff without a lot of hand holding. We give them some help with where data is missing and things like that, but they really are have gained a great deal of expertise that won't go away when this trial ends. So thanks.
Work, Syed. Thank you so much for presenting it. It's obviously a very challenging but necessary environment, as you pointed out, and we're very privileged to have these international collaborators. My question was, this is a great longitudinal experience for you. What can you comment on the cultural and infrastructural barriers that you encountered in setting up this study, or more broadly in terms of how you can change medical practice?
Yeah, it's a great question. Obviously, there's many barriers, especially in the beginning, and I think the hardest study was probably the first one, where Dr. Shearer was kind of the man on the ground with the original femur study. So thankfully, like the coordinators were there, they were already employed. I think it can be hard to kind of get everyone to be involved. So something like this type of trial where you're enrolling 13 patients a month, you need to identify all those patients, like they come in any time of day. You need the resident to communicate to the research team who has to come in the middle of the night, to enroll them. And residents aren't getting paid for this. And, so I think just getting buy-in from everyone and having them see the importance of the trial and being willing to do a little bit of extra work because it benefits, their healthcare system and their mode of practice is one of those key things that I think really helped. And when we got the residents to kind of see the benefit of the trial and how it could help them and change their community, I think that was one of the big things that helped, especially in terms of getting the trial off the ground. Other things, I mean, obviously there was a lot of logistical challenges. Anyone who's been there can tell you that. But I think you can find solutions and find workarounds. I mean, UCSF for some reason decided to block all East African IP addresses for like 3 months while I was there, which was not ideal. So we ended up having to get all the coordinators a VPN so that they could continue to use RedCap. So just like things like that you don't really predict, but pop up all the time.
Any other thoughts or comments, Dr. Ma?
Sterilizing the circuit. But Syed, a great job. I think you hear the sentiment of the department. I will also, want to just push back a bit over there in terms of this is what we do, right? This is what evidence-based medicine is. If we don't know the answer, we need to study it. If you actually found the right, if you have the answer, believe it, right? So I will push back in terms of, what you mentioned earlier about, spinal surgery, young patient. Take the sentiment out of how you practice medicine. If we need to practice evidence-based medicine, there are a lot of things we do is, I think it's right. If you believe in a trial, you think the trial is done right over there, you're gonna stick with the results over there. That's my last comment over there. But I would encourage you, the people in the department too, is if there's something that we don't know, study it. That's what we're here for. I think that's important. Thank you.
Dr. Diab, I remember being at this meeting probably 15, 20 years ago, and you were a visiting professor. And do you remember this comment? Okay, so doctor, because I think we need a little bit of levity in this critical time, but you remember the comment. Do you want to finish it off or can I give the punchline? Okay. So he gave a very eloquent talk with his usual style. And Dr. Bradford, our distinguished chair at that time, one of the most famous spine surgeons in the world, asked him a question. And Dr. Diab's response was, Dr. Bradford, I beg you not to be an anecdotal surgeon. And that's what I call this was a pretty much a job talk, but he pushed back against our chair. So in terms of the Vanco powder, do you feel the same now? Because is that anecdotal care? And will you change your practice based on the fact that most studies now are equivocal at best?
So the answer is, I have become the thing I criticized 20 years ago. And beyond that, yesterday in the OR, I'm with Dr. Petrie, and I asked her about putting a drain in the wound. And is there a study that shows that there is no impact, whether you put a drain in the wound or not in AIS? And she didn't know. So of course I told her it was our study that showed that there's no impact. And yet I put a drain in the wound. So I know Dr. Ma's blood pressure is going up here because we're not practicing evidence-based medicine. It's really difficult in surgery to practice all the time evidence-based medicine.
There's a difference between evidence-based medicine and evidence-based practice. Evidence-based practice takes into account experience and all the other factors.
All right. So I think with that, we'll wrap up. But Syed, congratulations, great work and great presentation.